Right, so we've reached 12:05, so I think we'll get going now. Quick introduction and some basic rules, really, I suppose, bit of housekeeping. This session is going to be recorded and it will be shared with the attendees, but it's also going to be uploaded onto the website that we have, as well as our YouTube site. As previously mentioned, just keep your cameras off and your microphones muted. And please do add any questions to the chat. We have got a panel coming up later on, but if you want to ask any questions, we will go back to them and find answers for you. Okay, so just to start off, I want to welcome everyone who's joined us. I'm Charlotte Hitchcock, and I am the Associate Director of Nursing and Midwifery for what's called the Central and South Genomic Medicine Service Alliance. I'm really thrilled to have people here today. We have got a really interesting agenda. Today it is for International Midwives and for International Nurses Day. We just chose a date that came after it all. And we wanted to combine the two because genomics takes a lot of importance over both specialisms. And we also wanted to demonstrate that we're very much a united force within the GMSA. As I said when we started, I'm Charlotte Hitchcock, and I am the Associate Director for Nursing and Midwifery for Central and South GMSA. So if you want to know exactly what that is, because we tend to quite happily refer to us as the GMSA or CAS, I'm just going to give you a bit of background into who we are and what we do. So there are 7 genomic medicine service alliances throughout England, and for the most part, we're all made up in exactly the same way. We all have directors of nursing, lead nurses, and lead midwives. There are combinations, I suppose, where we look at it and we could say that some of this does definitely not correspond to what is the NHS England regional divide. So if you look at us, we are Central and South, and here we are in the purple. We cover a large area, approximately 10 million population, and we cover the whole of West Midlands, Thames Valley, and we also cover Wessex. We don't go into east of England, but the NHSE is the Midlands. So a lot of people can feel quite confused about who actually might be responsible for their GMSA. What I would also say about that is once you've listened to everything that's going on today, if you want to contact the people from your own specific GMSA, if you can't find the link for them, please do contact us and we can send you any details for them. So what do we do as a genomics GMSA? What are we actually doing? We're looking at improving outcomes and being able to find out more about the cause and treatments for specific conditions. We can start looking at greater screening. So why are we involving nursing and midwifery? Why is that so important? Well, I think probably as the majority of you on here are more than likely nurses and midwives, you'll be saying, well, it's obvious. We are the major workforce. As you can see here, the numbers as of September 2024, they've actually gone up in the last year. They've been going up every 6 months recently. The only one that has dropped has been dual registration, where people have decided to either be nurse or midwife. And of course, some of that has to do with the training that is on offer as well. So what is our role? Well, what we say with genomics is that it is relevant from the time where you are conceived right through to death, but actually also beyond. And I would also put in that we are there as well pre-conception, and that is part of the screening component of this. So we can actually also be there to provide indication of risk, potential risk to people when they are considering pregnancies. We're there throughout every part of this, and we're known, as Duncan said in his talk, as the most trusted profession as well, because we're the people that patients, families, etc., tend to feel easier about talking to. So this demonstrates to me why it's important that we, as midwives and nurses, should be able not to give detailed description about genomics and explain all the minutiae of exactly what the genome is, but we should be able to understand the implications that genomics has on the healthcare of our population. And it means that we need to have an ability to signpost where we are able to, and to also make some links when we're talking to patients about their histories. So where is genomics relevant? Well, if you look at this, you'll see that it goes across every single specialty here. We do renal, pathology, it's in urgent and emergency care, audiology. Now, when we look at a genome, so the genome is the entirety of our DNA and the genes. And to read that takes masses of time. It would take far, far too long if someone wanted to sit and read the library, which contains the printed out genome. Ultimately, what we're looking for is a spelling mistake, a spelling error, something that is not quite right. And that's why we refer to these as genomic variations. So if you actually look at this list here of all these areas where genomics is relevant, there is actually a spelling mistake. But I would think that majority of people will have just looked at this and taken it as read, that that's all completely fine. But there is a spelling mistake. And in many ways, this to me reflects the fact that when we can be looking at something in a genome, which is massive, what people are looking for is something so tiny. And that spelling mistake might make a massive difference to someone's life, or it may not do anything at all. So the spelling mistake, if anyone wants to know, is ophthalmology. And to be quite honest, it's something that I picked up on it and I decided to use it. So genomics is relevant everywhere. Are the benefits though? So the benefits here are looking at prognostics, how we can look at the preventative approaches. We can start to look at individuals who may have a predisposition for a specific condition, but we can also look at parents who may carry genes which mean that when they are together, the child that they have may be affected by a condition that they themselves don't have but are carriers for. We're looking at the ability to provide earlier diagnosis, and that's really important within the NHS at the moment. We're opening more and more early diagnostic centres, and we're looking more at the potential of proactive advances. Earlier diagnosis also means that we can start to look at preventative treatments as well. And these precise diagnostics, which are based on the individual rather than the whole of a condition. So this truly goes back to the holistic way that the majority of us have been taught to think about nursing, that we're looking after the whole, we're looking at individuals holistically. We're now not just looking at Mrs. Jones, Mr. Brown, we're now actually looking at the specific condition that they have and how it presents and what the genetic components are, which may influence treatment, as well as looking at its presentation. So that precise diagnostic allows for more effective treatments. And we see this in many cases. And from the 100,000 Genomes Project, which was run between 2015 and 2018, we've actually been able to determine specific results and look at drugs that are going to be detrimental to health, but can also be far more positive in the way that they treat individuals. We're looking at fewer adverse reactions. And again, that's because we're able to look at the genome of the individual and see what may or may not cause problems. A lot of money is spent on medications which actually do not have an effective reaction, but can produce an adverse reaction, which then increases the expense of that. With all of these benefits, we do have to also look at the fact that what we're all very well aware of at the moment within the NHS is that times are hard financially. And so if we can find ways that we can start to reduce costs, we're not only then looking at reduce of financial costs, but we're looking at the reduction of costs to individuals who may get to a point with, for example, a chemotherapy, that they have had an adverse reaction to 2 rounds of different chemotherapy and say, I can't do any more. I feel too ill. And they don't take that 3rd one, which might have been the one which would have been okay with them. So this is now enabling us to look at what treatments are not necessarily going to work and how we can adapt that. We're also able to start looking at the eligibility for clinical trials. Are we able to start saying that people who present in a specific way and have a specific genetic variation might be eligible for clinical trials that otherwise they may not have been considered for previously? All of this adds to the benefits that we are able to provide for people. So, having given you a very, very brief outlook on what we're doing as GMSAs and within nursing and the importance of genomics to us, I'd like to introduce you to Karen Creed, who is our lead midwife.
Thank you, Charlotte. I'm just going to take control of the screen. Just bear with me so I can move my slides. There we go. Thank you. So thanks for the introduction, Charlotte, and hello to everyone on the call today. And by way of introduction to my talk, I'm going to start off with a little anecdote. And that is that about a year ago, I bumped into an ex-colleague of mine. She's a midwife as well. And she asked me what I was doing now. And I said, oh, I'm lead midwife for Genomics. And she went, oh, Genomics. She goes, I can't be bothered with that. She goes, I'm not interested. I just want to practice normal midwifery and focus on the basics. So we had a little chat at that point, and it's that conversation really that forms the basis of my talk today, because what I wanted to get over to her and what I want to get over to you today is that we are all genomics practitioners now, and genomics isn't niche or specialist anymore. As midwives, we're working with genomics every day, even though I think sometimes we perhaps don't always realise it. So in this talk, I'm going to give an overview of why genomics matters and highlight just some examples of how genomics is increasingly making a difference in maternity care, and in part also reflect on how genomics has developed during the course of my career, which is now scarily over 30 years of practice. So let's just move on. So I'm going to start off with this document. This will be familiar to midwives, and of course we've got one similar for nurses and for specialist community public health nurses, and this is the NMC document, the Standards of Proficiency for Midwives. And of course this represents the skills, the knowledge and the attributes that all midwives must demonstrate in their practice, and it now includes the terms genetics, genomics and epigenetics. And so these are terms that all midwives must understand and be able to apply to their everyday practice. I'm not sure how many midwives realise that these words are actually in there. And on this slide, I've just put one of those standards from Domain 6, and it makes it clear that all midwives should be able to apply an in-depth knowledge of of genetics, genomics, and epigenetics to inform the assessment, planning, and provision of care for the woman and the newborn infant across the continuum. So let's have a look at that continuum in more detail. And I think this slide is fairly self-explanatory. It's just looking at what I call the 5 Ps in terms of starting at preconception care, which Charlotte mentioned in her talk, and then moving on to pre-implantation. So this is the world of assisted conception and fertility treatment, and then moving around to perhaps more traditional midwifery care in terms of prenatal, also known as antenatal, perinatal, which is care during labour and birth, and then of course postnatal period, and then maybe on to another pregnancy in the future. So what I'm going to do is have a look at each of these areas in turn and just give you a few examples of where genomics, genetics, and epigenetics shows up in our everyday midwifery practice. So starting at preconception care, and you see on this slide we've just got a picture of a consultation and a drawing of a pedigree or a family tree, and in an ideal world we would have those discussions to explore genomic risk, explore kind of past medical history and family history and concerns about inherited conditions before someone actually conceives. And of course, then we can talk about the chance of their baby being affected with a specific condition. We may do testing to find out if there is a risk or not. Of course, in some cases, we might be able to tell couples that actually there's no risk at all, and that can be very reassuring. Some of these decisions or discussions may also surround the impact perhaps of a maternal genomic condition on how we might manage pregnancy and labour and beyond. And again, some of these discussions may ultimately influence whether a couple want to embark on a pregnancy or not. But some genomic testing, as you'll hear in a minute, is available as early as 8 weeks in pregnancy now. So if a woman doesn't present until she's pregnant or late in pregnancy, that limits the time in which we've got to do genomic testing. So if we can have some of these conversations before someone gets pregnant, then obviously that speed things up during the pregnancy itself. Now, what I've also done on this slide is put a picture of a no smoking sign, and this is to represent some of the lifestyle advice that we might offer preconceptually, and of course also antenatally. There's a crossover here as well, and this is one example of how midwives are working with epigenetics. So if I'm talking about epigenetics, I'm talking about how our external environment, how our diet, how exercise and other lifestyle factors can interact with our genes to influence or modify how they're expressed or how those genes might work. And I think smoking is a really good example. And we know that in utero exposure to maternal smoke can have long-lasting effects, not just on the health of the fetus during pregnancy, but also for that child after birth and during the course of their life, and potentially for future generations as well. And we now know that in part, some of this effect is due to epigenetic changes. I think it's fair to say that we're only just at the beginning of our understanding of the role of epigenetics. And I think there's going to be far more on this subject coming out in the years ahead. So, there we go. Secondly, I just want to move on to pre-implantation. And I think while very few midwives perhaps work directly in the area of assisted conception, all midwives need an understanding of some of the technologies that we currently use in this area and why we might be using them. Pre-implantation genetic testing is where we have an embryo and we take a few cells from it to look for a specific genetic condition that couple might be at risk of, and then we only re-implant healthy embryos back in the womb, and that can avoid conception of a baby with a certain genetic condition. We also need to consider whether perhaps they've used donor gametes to conceive, and if so, maybe they did that to avoid a genomic condition perhaps in one of the parents. And where egg and sperm donors are used, of course they may be anonymous donors, and that's important to know, because if they are anonymous donors, then there may be unknowns about their family history and their medical history, and we won't be able to fully assess genomic risk in those cases, and therefore we may need to use that information to be able to plan care and offer tests appropriately going forward. Next, we want to come on. Oh, sorry, that's just there. Go back. So Next, I just want to come on to the next two areas. So first of all, prenatal, also perhaps more commonly known as antenatal care. Now, this slide, I think, if you're not a midwife, probably looks quite complicated, but I'm going to talk you through some of the areas on this slide. So let's start off at the beginning, at booking, and that's the first appointment that a woman or person might have in pregnancy. And at that appointment, we ask a lot of questions about medical history, family history, history of the partner, and so forth, to try and understand whether there are any genomic risk factors in that particular couple. And we often call these genomic red flags. And where we find those genomic red flags, then it may be that the midwife needs to refer for specialist genetic counselling or further testing, or perhaps further input from an obstetrician. And of course, I think it's a really interesting time in pregnancy because it might be the first time that a woman or a couple have thought about the impact of inherited conditions, and probably the first time that they've actually explored it in detail with a healthcare professional. And sometimes some factors may come up that might not be directly relevant for the pregnancy. So let's think, for example, perhaps we've got a woman who's got a very strong family history of breast cancer. Well, she may have further questions about that. And whilst that may not directly impact maternity care, the midwife can signpost her where to go for further discussions about that. Also in pregnancy, we have the 3 NHS antenatal screening programs. And many of these programs are screening for different genetic conditions. So for example, we offer screening for sickle cell and thalassemia to all women in pregnancy. And of course, these are autosomally recessive inherited conditions. And so all midwives need to understand autosomal recessive inheritance in order to assess risk and offer screening appropriately. We also offer fetal anomaly screening for Downs, Edwards, and Patau syndromes, and these are known as trisomy 13, 18, and 21. So again, all midwives need to understand chromosome conditions. And where, of course, we have an increased risk of trisomy on screening, we can now offer non-invasive testing. So non-invasive testing involves taking a sample of maternal blood to analyse some of the DNA that's come from the placenta and is found within the maternal bloodstream. We can use this for testing in terms of looking for an increased chance of conditions like Down syndrome and Edwards syndrome and Patau syndrome. But we can also now use this technology for, in very few specific cases, for diagnosis. So we can actually diagnose some genetic conditions that are found in the fetus just by taking a sample of maternal blood. Later in the pregnancy, we offer fetal anomaly scanning. And of course, where we may identify structural anomalies on that scan, that can result in the offer of genomic testing in the form of whole exome sequencing. And midwives may be involved in supporting parents, of course, who are going through that testing process and waiting to get results back, which can be a very uncertain time. And you can just see on the bottom here, not sure if my mouse will point to it, but the number there, R21. And R21 is the code for rapid whole exome sequencing in pregnancy. And it's the test indicator code from the National Genomic Test Directory. I'm going to talk more about the test directory towards the end. So moving on then towards perinatal, so that's labour, care during labour and birth. So we may also use our knowledge of genomics to help plan care during pregnancy and labour, whether it's perhaps to prepare for the birth of a baby with either a suspected or a confirmed genomic condition, or it might be to support a woman who has a genomic condition herself. And let's think of an example. So, for example, when I started my midwifery career, it was very, very unusual for a woman with cystic fibrosis to conceive and then go through pregnancy. But now it's becoming increasingly common. And the reason for that is our understanding of genomics has improved some of the drug treatments that we can offer for some people with CF. So though more and more women with cystic fibrosis are now conceiving and having babies, and therefore more midwives are going to meet women with these kind of genomic conditions going forward. And of course, that brings challenges for us as midwives in terms of supporting them through pregnancy, birth and beyond. And then the final P is in relation to postnatal care. And this doesn't just have relevance for midwives, but also if any of you on the call are perhaps health visitors or neonatal nurses, then it's also relevant as well. And so let's think about where genomics shows up in the postnatal period. Well, firstly, a midwife, one of the first things we do at birth is assess the baby to look for any markers or any anomalies that could indicate there's a genomic condition in the baby. And that's something that we just automatically do when the baby's born. We also have 3 NHS newborn screening programs. And again, the majority of the conditions that we look for on these screening programs are genetic in origin. So if you think about hearing screening, then around 50% of cases of hearing impairment have a genomic cause. If you think about newborn blood spot screening, we are looking for up to 10 different conditions, all of which are either wholly or partially genetic in origin. So again, we need an understanding of the genetics of some of those conditions if we're offering these screening programs. It may be that we have a very poorly baby after birth and that baby's in the neonatal unit. And in some cases, we may want to offer whole genome sequencing to understand what's going on in that baby. So R14, again, that links to the National Genetic Test Directory, offers rapid whole genome sequencing to the acutely unwell baby in neonatal unit and to children in pediatric intensive care. Charlotte also mentioned how we can use genomics to help prescribe certain drugs, and I've also put R65 on here. So this is all about pharmacogenomics, and so pharmacogenomics is basically the study of how a patient's genome can influence how that person responds to medication. And that response might be in how effective that drug is or whether they get side effects with that drug. And what we've identified is that there are 3 genetic variants that are associated with hearing loss after receiving aminoglycoside antibiotics. The most common of those antibiotics is gentamicin. So that's probably one that most midwives will have heard of. And if we can test someone before they receive those antibiotics, and if they've got one of these 3 variants, we can actually try and avoid prescribing them. Now, you may be aware that neonates are more likely to receive this group of antibiotics than other groups of people. So they're actually doing some work at the moment to assess the feasibility of routine point of care or bedside testing in neonatal units so that we can test babies perhaps before a point at which they might receive these antibiotics, and that reduces the chance of hearing loss in babies that have got this specific genetic variant. And then last but definitely not least, I've also just put on this slide information about fetal loss and pregnancy loss pathways. And we can use genomic testing to help identify, in more cases, why someone may have lost a baby at any stage during the antenatal or sort of immediate postnatal period. Not knowing why can be very difficult and increase parental distress at this time. And research suggests, for example, that genomic testing can provide answers in more of these unexplained cases. And that not only helps parents in come to terms and understand why it might have happened, but also provides valuable information for future pregnancy planning for that couple. So I think I've given an awful lot of information on those few slides. I'm going to, at the end, direct you to further resources where you can find out more. In recognition of increasing prominence of genomics within everyday midwifery, we have a national lead midwife for genomics who's based at the Genomics unit at NHS England. And we now have a lead midwife in 6 of the 7 genomic geographies that Charlotte talked about at the beginning. We have a national MIGS net, so MIGS stands for Midwives in Genomics and Genetics Network. And this is made up of a variety of health professionals who've all got an interest in genomics and maternity care. And as a group, we're helping to lead and contribute to a variety of work streams and projects, which are all working towards further embedding genomics in everyday practice across that maternity continuum. And what I've chosen to do is just pick a couple of projects just to give you a couple of ideas as some of the work that's going on the next couple of slides. So to start off with, I just want to talk about the culturally sensitive genetic service. And this is a pilot by NHS England. They actually launched it in their 3-year delivery plan for maternity and neonatal services, which was published in March 2023. And within that document, they committed to piloting a culturally sensitive service for people practicing close relative marriage or close relative relationship in high need areas across England. And of course, these are an important group of people because we know that children born in first cousin marriages have approximately double the risk of congenital anomaly. I think the background risk actually for having a baby with a congenital anomaly is around 3%, but in close relative relationships, it can increase to around 6%. And of course, some of the communities that perhaps are more likely to practice close relative relationships perhaps are perhaps more of the sort of underserved groups and perhaps have lower awareness of some of the genomic services that are available to them and some of the testing and support that is available. So a culturally sensitive service can work by putting specialist midwives working at that community level to help raise genomic literacy amongst communities, help improve access to genomic services for these underserved groups, but also working in parallel with the wider maternity workforce to raise awareness of some of the issues and the need for urgent and prompt referral, or certainly the offer of referral. And this project is already well advanced underway in 8 areas of high need across England at the moment. And what we hope is that some of the outputs from these localised projects will then use to benefit care across all areas in England going forward. Secondly, I very briefly want to mention the Generation Study. So the Generation Study is probably one of the most important research programs in genomics since the 100,000 Genome Project. The aim is to sequence the genomes of 100,000 newborn babies in England to look for around 200 medically actionable but rare genetic conditions that are treatable. I think this is going to further raise the profile of genomics across England and highlight the potential that it might hold for the future. Now, it's already underway at selected sites, but I'm not going to talk any more about this because my colleague Fern is going to talk more about research and genomics and this study in the next talk. So one of the things that we're trying to do is work with midwives, encourage them to be more genomic curious. And there are a variety of resources out there to help midwives upskill and stay up to date with the latest advances. And I think it's particularly important for midwives who perhaps qualified a long time ago, like myself. But there are lots of resources out there. We've got the NHS England Genomics Education Programme, and they have lots of information on genomics and training and some specific in relation to midwifery. And there's some like really small little bite-sized learning videos, sort of 1-2 minutes long, and going right up to information on a master's degree in genomics if you're particularly interested in this area. We also, of course, have the NHS Learning Hub, which is transitioning from e-learning for healthcare. And on both these sites, we have a variety of modules, many of which have a link to genomics, and some of the modules that's just worth pointing out, I think, are the ones on glucokinase, which is a form of monogenic diabetes. We have learning modules on screening for glucokinase in pregnancy. We have modules on close relative marriage and sort of genetic risk associated with that. We've also, of course, got the modules on antenatal and newborn screening. Of course, like as I've said, many of those conditions are genetic in origin. We also have a range of resources available. So the National Genomic Test Directory lists all the genetic tests the NHS England commission on behalf of the NHS in the country, and it's constantly updated as we learn more. Then there are more tests available. So if you want to know what's available, you can go and have a browse through there. It also lists the eligibility criteria for each test and which professionals can order those tests. I've also put a link to the red flag prompt cards. Now, these were developed by a colleague of mine in northeastern Yorkshire, so particularly useful for midwives in terms of highlighting some of the questions that we should be asking at booking to ascertain if there are any genomic red flags in somebody's history, and also talks about how to refer and when to refer to specialist genetic counselling. And finally on this slide, we've just got G notes. So G notes stands for genomic notes, and these are genomic notes for clinicians, and there is an area on this site for fetal and maternal health. So if you're working clinically and perhaps you've got someone who's got a genomic condition, you might want to type that in and find out more about it. If you want to know more about some of the tests that I've mentioned, such as non-invasive prenatal diagnosis or whole genome sequencing or whole exome sequencing, you can just type it in there and get a quick definition. Now, there are lots of resources and information out there, but it can be difficult to know where to start with your genomics learning. So one of the things we've developed in Central and South is the Genomics Learning Passport for midwives. And the idea behind this is that it guides you through the key learning resources. It starts at the very basics. So what is a gene and what is a chromosome, for example, and it's okay to admit that you need a refresher on those kind of topics, but then it increases in complexity and moves up to specialist, more complex areas. It's a Word document, so you can download this document and you can edit it freely. So it enables you to record a sort of bespoke genomics learning journey, and it does so in a format that you can use for your revalidation. We've also developed one for nurses, and I know my colleague's going to talk about that later on as well. And we've also got a passport coming out very soon for health visitors and specialist community public health nurses. So finally, this is my final slide. I just wanted to sort of bring it all together and summarize, really. And on the left on this slide, you've got a scene from Call the Midwife, which many of you know is a BBC TV series showcasing midwifery in the 60s, which was a very different era. They had no scans then, of course, and they didn't have any genomic testing, even though some of the storylines do involve sort of genomic conditions. And then we move forward 10, 20 years, and we've got this quote from May's Midwifery, which is a seminal textbook on midwifery. And this quote here could really apply equally today. So in 1989, they wrote, "The pace of advance in our understanding of inherited disease is rapid and accelerating, and these advances are making a considerable impact on the practice of obstetrics and midwifery as elsewhere in clinical medicine." So 1989 is interesting because that is the year when they first diagnosed the first genetic variant that was causative for cystic fibrosis. Before that time, we knew it was inherited, we knew it was genetic, but we hadn't found the variant or a variant that caused it. And of course, once we started identifying genetic variants as a cause of genetic disease, it opened the door of possibility to expanding the range of prenatal diagnostic tests that we could offer during pregnancy. And so going forward through my career, I mean, when I started, not all women got a dating scanning pregnancy. But since that time, of course, we can offer amniocentesis and coronate villi sampling as invasive testing for genetic conditions. As I've already mentioned, we can offer pre-implantation genetic diagnosis to avoid the conception of a baby with a genetic condition. And then, of course, more recently, we have non-invasive prenatal testing and diagnosis, which avoids the risk of miscarriage associated with invasive testing. So things have changed an awful lot during my career, and we've come a long, long way. Our understanding of genomics has rapidly increased during this time. But what hasn't changed in midwifery practice is that relationship that the midwife has with the woman and the person in her care. And that for me is what's at the heart of midwifery practice. And it's important, as important now as it was in the time of Call the Midwife. So if we return now to my ex-colleague who I mentioned, who said she couldn't be bothered with genomics. I don't think for 1 minute that she can't be bothered with genomics. What I think that is a reflection of is the fact that we have a problem sometimes with the G word, with genomics itself, and that sometimes that word can create a barrier. It sounds a bit sciencey, doesn't it? A bit niche and a bit specialist. But what I hope I've shown you in this talk is that genomics is already interwoven into so many aspects of maternity care. And if midwives can embrace genomics and talk about it with confidence, then it can only serve to enhance midwifery practice and enhance that relationship we have with the people in our care. And that knowledge can empower those families going forward. So that's all I was going to say today. My email address is on there, and you're very welcome to contact me if you've got any questions going forward.
Thank you, Karen. That was really good and very interesting. I'm sure that a lot of people now are feeling a lot happier about the fact that there are various sources that they can go to find out more. And it's also always encouraging for everybody to realise that genomics really is there for everybody. It doesn't have to be scary and scientific. I'm always very grateful for that, because I'm definitely not desperately scientific, but I'm very well aware of the implications that genomics has to healthcare. So moving forwards, I'd like to welcome Fern, who is going to talk to us. Fern Adams is a research midwife, and she's based at Birmingham Women's and Children's Hospital. And she is also taking a really, really important leading role within our generation study, as mentioned by Karen in her last talk. So Fern, welcome.
Thank you, Charlotte. So I can take control of this. Yeah, sorry. So yeah, thank you for the introduction. So yeah, as Karen said, my name is Fern. I am a midwife, and I am the project lead for the Generation study at Birmingham Women's and Children's Hospital. And I've been asked to give you a whistle-stop tour of my journey into genomics, research focusing on the Generation study. So, oh, it's blocked actually. Sorry, it won't let me take control of the slides.
I'll move them for you. Just let me know when to get to the next slide.
Oh, okay, thank you. Next slide, please. Lovely. Oh, yeah, next slide. Thank you. So why do we do research? We all know research underpins all of the care that we give. And you can see here a couple of quotes about that. And as a health professional, we all want the best care for our women, birthing people and families. Yet the picture to the right is often what we see when discussing it. So I have worked in clinical research for over 10 years, and I'm going to tell you a little bit about why. So I started off as a healthcare assistant, qualified as a nurse, worked in oncology, a hospice, fast-paced medical ward, critical care, became a midwife, absolutely loved clinical care, and worked in community, delivery suite, postnatal and antenatal wards, and on a busy maternity unit. I fell into research as it suited family life, and I didn't ever want to compromise the care that I was giving, really, by leaving on time as a very sleep-deprived new mum. However, what I soon learned was I love research. It enables you to spend more time with patients and actually talking to women and listening to what's important to them. So when I was really new to research, I went to a study day where someone said to me, as a midwife, you spend your whole day giving the best care that you can to one lady. Whereas as a research midwife, you are helping all women receive the best care. Now that really resonated with me, as that's surely why we all join the profession. Next, please. Next slide, please. Oh, lovely. Sorry.
Come back?
Yes, thank you. So a research midwife plays a vital role in advancing evidence-based midwifery practice by conducting research, supporting clinical trials, and ensuring the highest standards of care for research participants. On a daily basis, we screen and recruit participants in studies. We collect data. We monitor participants' wellbeing in the study, and make sure everybody is adhering to study protocols to ensure data integrity and also patient safety. So staff engagement is a really big part of our role, and increasing the research profile. We spend a lot of time training and obviously administering the intervention being research, whether that be medications, devices or clinical care. And what I'm going to talk to you a little bit about is sort of the role in genomics. So next slide, please. So the evidence is that women have 25% better outcomes when participating in research studies, so or even receiving care at a hospital that is research active, even if not in a study themselves. So Birmingham Women's really is testimony to this. So we bridge the gaps in care for women that we see, regardless of whether they choose to participate or not. So, for example, making appropriate referrals to clinical genetics that may have been missed by other busy professionals, which are often massively impacts their care decisions. So this has a really positive impact on our women, particularly when for women whose first language is not English. Next slide, please. So currently I am working on the Generation study, which is a long-term research study offering a genomic screening for rare genetic conditions, fully funded by Genomics England, with a very broad eligibility criteria for participants. So almost all of our birthing people are able to participate. So it aims to understand if we can improve how we diagnose and treat genetic conditions, targeting the diagnostic odyssey for children. As we know, early intervention leads to better outcomes. So we aim for a cord blood sample at birth and only request a capillary sample if that is missed. Next slide, please. So I can't talk to you today about the Generation study without noting that the 100,000 Genome Project led the way for the infrastructure, really laying the groundwork behind the study. This also gives you the backstory as why the study is so important to me personally, but also to the outcomes of the families that we approach. So this is my rare boy here who received an initial diagnosis of variant of unknown significance from the 100,000 Genome Project, which I self-refer to as I work in research and actually wouldn't have known about his project otherwise. So as more researchers become available, his condition now has a name, and that's just in itself life-changing as a family. But as a healthcare professional and experienced mom, I was not listened to with concerns about my child, despite him having many complex medical needs. Referrals were lost or not made. So I had the knowledge to chase this up. Most families are not able to do this. My little one now in the middle, he attends a special needs school and has multiple health needs. So without genomics research, my little boy probably would have been one of the 6,000 children born each year that are part of this one generation, so syndromes without a name. So as we did not receive answers from standard NHS care, never knowing answers, questioning if you did something wrong in the pregnancy, and really living in isolation with nobody really sort of understanding your struggles as a family. So with the Generation study and the advances in genomics and research, we really have a chance to dramatically impact so many families' lives and outcomes. Next slide, please. So the study has three main aims. So it's to identify rare conditions in babies earlier, therefore helping each individual family taking part. And it will do this by sequencing the genomes of up to 100,000 newborns. So enable research. This is done via the National Genomics Research Library, anonymised data, which researchers can use to work on new treatments and understand how we may better diagnose genetic conditions. It explores the risks and benefits of storing an individual's genome over their lifetime, and the study will also provide an evidence base that will guide future screening practice and policy. So each child participating is screened for over 200 genetic conditions. Now there's over 7,000 rare genetic conditions, and collectively, though, they are quite common. So 1 in 17 people has a rare genetic condition. So the conditions selected as part of the Generation study are done so as they are all ones that show in early childhood, usually under the age of 5. And most importantly, all of the conditions have treatment options to dramatically impact those outcomes for those children within the NHS. Next slide, please. So the feedback from our women has been extremely positive. We have a consent rate of about 50% if we include women that are directly approached, and also the self-referred women. We have recruited, as of today, 1,120 participants into the study since we opened to recruitment on the 10th of June. making us one of the highest recruiting sites. So you can see on the screen the comments from our women. The questions we get asked most about the study is whether delayed cord clamping is possible. And so we've obviously altered what we say as a direct result of this, and explained to women they can have delayed cord clamping, and any clinical bloods are taken. All the care remains exactly the same, and only when mom and baby have finished with the placenta and cords do we take the samples. Obviously, we get questions about data storage, and that's probably one of the other biggest reasons of why women do decline the study. So the most common reason provided is women not wanting to participate in research or wishing to have standard care. So, however, some women don't give a reason. We have had some women decline due to religious reasons, and this is certainly an area that also needs more exploration. So the study is storing the genome of the baby, and therefore the father of the baby also needs to be happy with the study if mom is in contact with him. Next slide, please. So as a team of research midwives, we really are starting to see a positive impact for our families. Condition not suspected results are issued directly by Genomics England. GPs are also informed. But for the returning of condition suspected results, within our team, we have one of Central and South results coordinators, a midwife covering University Hospital Birmingham and Birmingham Women's Hospital, therefore 4 hospitals. Her role is to liaise with the clinicians when there is a condition suspected result. For the conditions that are part of the newborn blood spot screening, we liaise with the screening team prior to issuing any results. And for each of the conditions, there is a mapped pathway. We're extremely lucky really here in Birmingham, as most of these participants will be seen locally. For some of the highly specialised services, they may be seen at specialist centres across England, and travel costs are then reimbursed. So the benefit for our families really is that the very first person to inform them of a condition suspected result is a specialist in the condition, usually a consultant, and they will stay under that care team. Each one of the conditions selected are treatable. They're not waiting for lengthy appointments and referrals, and some of the conditions included are ones that are hoping to be added to, or soon to be, to the newborn blood spot screening, so tyrosinemia and SMA1, which really is life-changing. So we have close links with genetic counsellors that have some funded time by the Generation Study and available for advice as required. Next slide, please. So these figures are a little out of date now, but highlights the impacts for families. So you can see the amount of samples sequenced, and we have had 23 condition suspected results returned. So unlike, and this is across the whole of the study, so unlike any other study, clinical staff have been really on board with this project. So I think this is also aided by support from management and engagement with team leads from the very beginning. So we receive referrals daily from women. This is absolutely unheard of in research usually. The screening looks very diverse. However, it's often professional women that are self-referring. That is changing a little bit now. I think that's probably from word of mouth. So you've heard how a diagnosis was challenging for my family. So when we think of families where English is not their first language, or families where that have learning difficulties themselves, the very families that would benefit the most from being part of this study, these are the families that aren't as represented. And this is the future challenge of the role of the research midwives within our team, so to ensure these women are represented. So next slide, please. So, and that's it for me. So I just obviously always finish with a cute picture of a baby, because who doesn't love that? And there is a little link there for for some more information about the Generation Study if you would like to look at that. So thank you.
Thank you very much, Fern. Thank you for sharing your own personal story, but also very much for sharing about the work that you do, why you've gone into research, etc. It was really interesting. So thank you very much. So next, I am really thrilled to be able to say that we have Dr. Kathleen Calzone, who is joining us from America. Kathleen has an immense CV, fantastic biography, and so I'm only going to give you a very, very brief part of that. She is a research geneticist in the genetics branch of the Centre for Cancer Research at the National Cancer Institute. She is a founding member of what is referred to as G2NA, which is the Global Genomics Nursing Association. And she is also supremely involved in education and training and the determination to have nurses involved in competencies for genomics so they practice effectively. So I'm very thrilled to be able to hand over to Kathleen, if that's all right with you.
Yes, absolutely. I have a mutation in my technology gene, so.
Kathleen, do you want me to move your slides for you?
I guess so. The share button doesn't work, so that would be
If you
grand.
can try it, yeah. If you have it,
I've tried it.
Yeah.
It doesn't work.
It doesn't
Okay.
work.
Yeah.
So I can move them on for you if you just let me know.
Okay. Okay. So if you could advance, please. Thank you. To the next slide. So I thought that the way that I would start is to kind of tell you how I sort of mutated into cancer genetics. I've always been in oncology, and after my undergraduate degree at Syracuse University, that's where I went in terms of my career pathway at the University of Michigan. And I did everything from inpatient, then moved to outpatient, then into a management role, and then ultimately got into a clinical research nursing role, mostly associated with drug development and therapeutic options for patients with cancer. And our largest cohort of patients were breast cancer. And so it was at that time, and now I'm dating myself, where the region on chromosome 17 was identified for BRCA1. Which is a gene associated with a predisposition to breast cancer. And of course, I didn't know anything about genes except that, I thought that I looked like everybody in my family, being a short, fat Italian. And so this was a big learning curve for me in regards to, what is this about? And I had the opportunity to learn from one of the greatest geneticists that I've ever worked with, which is Dr. Francis Collins, who was instrumental in involving our group in the identification work with a large international collaboration to identify BRCA1. And that's where I really learned about the value of working internationally. That led me and the research team to the University of Pennsylvania, where then we began the early work of doing genetic education and counseling. And it became clear to me that, I was working with a large segment of the nursing population who started like I did and really didn't have any understanding about genomics. That ultimately led me to the National Cancer Institute to pursue my own work in research and also clinical care with a focus on competencies. And that was driven in large part by work that was done in the UK by Dr. Maggie Kirk and Emma Tonkin and others that developed the very first competencies that I was aware of associated with genomics and nursing. And so not being shy at this point, having worked in an international space for quite some time, I, of course, had to reach out to these people. And after many long meetings, Maggie successfully, convinced me that I needed to pursue my PhD in nursing, and where better to do that than in Wales at their university with the people who developed this work. And so now I'm the head of the Genomic Healthcare section, which is a clinical section here at the National Cancer Institute. And my research is in genomics and implementation science. So next slide, please. And so the framework that I operate on is sort of the implementation sort of vision of who is the patient. And as you've nicely heard from some of our speakers already today, is that starts in the preconception and prenatal period and extends all the way to the end of life. And even in the context of cancer, that applies when there is the identification of a genetic predisposition to cancer running in a family, and they're trying to avoid passing that down. And there's a lot of opportunities for intervention to try to ameliorate some of those risks, but also ethical considerations. Next slide, please. And so the framework that I was working on from the perspective of implementation in nursing is that there is this interface between the academic community that prepares providers for clinical practice, the nursing professional organizations, the regulatory community that drives nursing practice from either licensure or other kinds of regulations, and the critical role of nursing leadership. You cannot do pretty much anything, and I speak from, obviously a US lens, without involving nursing leadership. And nursing leadership can be nursing leadership at the bedside to nursing leadership at a much broader scale. Next slide, please. So the place that we started following the model from the UK was to establish in the US, because of course we always have to do things different, what was the minimum basis of what is required for nurses to deliver competent care in genomics. And we did that in partnership with the American Nurses Association, which is the large body that represents all nursing within the US. And we convened a panel that included representation from clinical, education, research, and organizational settings. We crafted competencies, then we sent them out for public comment. We made revisions and then ultimately sent it out for endorsement. And these were intended to be the minimum, the sort of basis. And then we did a national nursing workforce study to kind of see where we are, like what is the state of the nursing workforce related to these competencies, because that informs where you go and what kinds of interventions you can use. And I'll speak to that in a little bit. What was clear is that over time, as these competencies were rolled out, we heard loud and clear from the practice, the education, and the leadership communities that they didn't know what they didn't know, and they needed not just competencies. What they needed were, specific areas of knowledge that were required to achieve that competency, and what would be clinical practice indicators. And so we developed a second edition on the heels of the first edition, addressing that. And over time, we've done a number of studies, and we haven't in the US made substantial progress. I'll give you some examples in the next following slides of what we have done. But the short answer is that we still have a lot of work to do in the US, and there is the need for an update to the competencies, because now we're not just in the genomic era, we're in the genetic era, we're in the genomic era. And so we needed to reflect the current state of the evidence. And so we did that with a Delphi study to update the competencies. And we have developed competencies for nurses prepared at a master's or above level using similar mechanisms, and that's also under revision. Next slide, please. And the framework that we worked with, we started with Rogers' diffusion of innovation, but when we think about implementation over time, there's been additional models developed, and we currently use the consolidated framework for implementation research. And the advantage of using a model is to think about, how easy is it to adopt something? What are the kinds of things you need to think about? How do you design your interventions? How do you measure it? Who do you involve? All of those variables. And so I bring that up just to get your mind thinking about how critical it is to think about all of those things and think about the fundamental piece of this, which is being able to sustain change, because that's very hard, particularly when you're thinking about genomics, where it seems like every day there's something different and something new. Next slide, please. So the very first thing we did is we needed to figure out how do we measure nursing capacity in genomics. Because if we're going to do anything in terms of interventions, we need to do that. So the instrument that we developed is the Genetic and Genomic and Nursing Practice Survey. Has continued to evolve over time with different kinds of assessments of it. But it's essentially evaluating things that we understand from these theoretical frameworks that are important, which is what is the nursing attitudes about this? What are they doing? How receptive are they to this sort of stuff? When, they are using genomics, how confident are they and what's their capacity? When we think about this, the DGMPS measures things in a common disease framework, not specific diseases, and that foundation is family history. And the reason for that is because that's applicable to really any nurse in any setting. There have been some knowledge-specific tools developed. I'll highlight the one by Linda Ward, which is the Genetic Nurse Concept Inventory, which is also really well done, very targeted towards knowledge only. And then we developed these clinical practice indicators defined by the competencies so that we have a way of really measuring whether or not we have success or failure in any intervention. Next slide, please. And we spent a lot of time thinking about the leadership framework because the leaders need to do things in a different way. And most leaders, I will fully disclose, have been pretty resistant to thinking about, well, that's a clinical thing. It has nothing to do with us. But actually, when you're thinking about teaching people about a new body of information that impacts healthcare, they do need to have considerable involvement, both from the perspective of training. They need to consider their business and financial plan and integrating the costs of those sorts of things. They need to think about the infrastructure to integrate genomics into healthcare delivery. So things such as point of care decision support, or the capacity to be able to record pedigrees that can be updated by the next healthcare provider, as opposed to just a single document in a health record that then everybody has to recreate every time that they see a patient. They need to have existing policies and think about even genomic advance directives. And they need to have mechanisms for, what is the scope of education, counseling, who can do informed consent, what kinds of referral networks do you need to establish? And those sorts of things. And how do you measure that you have staff capacity? And then there's the whole regulatory piece from the, NIH infrastructure of research internal review boards or IRBs to, the other kinds of support infrastructures. Next slide, please. So we started by doing a large implementation initiative after the competencies, and that was a method for introducing a new competency, which was genomics, but it's a model that could be used by others, and so that's MINC for short. And we do still have the toolkit and a toolkit that has both administrator and educator information. So this was done with magnet hospitals. In the US, there are specific kinds of hospitals that have met certain kinds of criteria in terms of excellence and care delivery that allow them to have this magnet status. And that meant that they all had that sort of underlying similar infrastructure and capacity. And we had multiple institutions involved in this initiative. And over 7,700 nurses participating in this. And we did both baseline and intervention, training people, both training leaders, but also training champions within the institution to kind of lead this initiative. Next slide, please. We also sort of following on my studies with the studies in terms of my doctoral studies, we were successful in beginning to think about what was already mentioned was the Global Genomics Nursing Alliance. where we were able to get funding from Wellcome to be able to pull together an international group of nursing leaders doing similar things to what I've just described in the US and what have been going on for some time in the UK, to be able to bring people together so that we could, think about how could we share what we're doing, and not have everybody reinventing the wheel, but to work together to both, conduct collaborative research across multiple countries, to be able to have a mechanism to share best practices, what worked, what didn't work, in a much more collaborative and rapid environment than, say, publications could get us at. And so there were 17 countries and 7 international or national organizations that were represented in that. And that resulted in the G2NA, which continues to exist as, an open access network. To join the network, you just have to email me. We don't charge. We offer quarterly webinars, and we've done a variety of different projects to try to support other countries. Next slide, please. In the G2NA, in addition, we've developed a couple of resources that I think are important for people to be aware of. One is the implementation roadmap, is to think about, well, we've done this work in the US, the UK has done a lot of work, there's other countries have started moving in that direction. And so what is it that people need to think about in terms of what does it take to actually move this out? And so the implementation roadmap is something that is a minimum framework that allows people, what are the things I need to consider in trying to do something in my own environment? And that environment could be a local environment, it could be a regional environment, it could be a countrywide initiative. And the assign tool is essentially a maturity matrix. It's a way to kind of look at, what are the enablers to being able to achieve something like, effective nursing practice that's incorporating genomics. And then what are the indicators that you're looking for? And so both of those tools are open access and is quite useful in terms of thinking about things. I think that the advantage of the G2NA has been the sharing of these kinds of resources that have been developed. I've shared the instrument, the GGMPS, to a multitude of different countries that have used it. And it's, something that I've made open access, meaning that, you can modify this for local context, because what's happening in your region is going to be very different than what happens in mine. And so that can affect some of the analytics associated with the instrument, but it depends on what you're changing. And as long as you go into that eyes wide open and do some additional assessments, it's still a valid instrument. And I'll highlight some of the sharing, this is a very recent initiative from our colleagues in Finland that published an ebook on their GenoNurse project, which is developed an educational model and a particular roadmap for teachers and students. Hugely valuable and open access. And so the URL is in my slides for those of you that may find that interesting and of value. Next slide, please. In the US, we have nurse practitioners, which are advanced practice nurses who have prescriptive privileges. And so we've been very interested, myself and my colleague Kathy Fulton, in the utilization of pharmacogenomics, which is being able to do a genetic test to inform medication selection, dosing, and so forth. And there are international guidelines, the CPIC guidelines. And so we wanted to really understand the landscape. Our hypothesis was that people were not using it, but we really needed to study that. And so what we found is that 84% of nurses that were nurse practitioners with prescriptive privileges, this was a study done only on those with prescriptive privileges, never used the CPIC guideline. Oh my goodness. So that was kind of startling. And we had 162 nurses who indicated that, they did not anticipate ordering a test. And so we asked them, why not? And they basically said it was because they didn't know what test to order. But this was in the face of many of these nurses saying that they had pharmacogenomic content in their curriculum. So that raised a big red flag. So if you don't know what test to order and you're not following CPIC guidelines, or we wish we had asked, do you even know about them? It makes you wonder about what is in the curriculum. And this is really a quality and safety initiative. So our current study is actually assessing the curriculum and really trying to understand not just what's in the curriculum and what they're teaching, but what is the faculty capacity to teach this? And that's an important component of, implementation. You have to think about the entire pathway because if faculty don't have the capacity to teach it, it doesn't matter what the curriculum says. It's not going to be as effective as it could be if all of the pieces were there. Our hypothesis is that we need to develop a model curriculum with supporting resources and faculty training to be able to address a deficit of this sort. Next slide, please. We've also done several national nursing workforce studies, which I alluded to, using the GGMPS. And we've done that associated with both the competencies as well as other intervention associated studies like the Ming project and so forth. But what I'll highlight for you is that we just completed a national nursing workforce study using the same recruitment strategies that we used when the very first competencies were developed. And that was something that disappointingly showed no difference from more than 10 years ago, despite all of the interventions and the evidence-based guidelines for the use of genomics in practice. It's a little disturbing, particularly because this cohort of nurses who responded to this survey, there were far more people prepared at a master's or higher degree level, and yet we still saw no difference. And we know that the GGMPS can detect knowledge differences from what I'm showing you here is knowledge core items. And so it's quite disturbing. And we're currently working with the American Nurses Association to try to determine how we're going to handle this. Next slide, please. So, I think what, my point in terms of genomics is to appreciate, I can say for the US perspective, that we know that nursing has little to no foundational underpinning in genomics. And that's different from other kinds of implementation change initiatives where, you have some foundation of basic healthcare context. And so being able to, add something new to your, knowledge base is much more feasible. And it's difficult because there's also limited capacity to teach this information. And the medical providers may be either extremely knowledgeable, but speaking above the level of the nurse, and using a language that people don't understand. Variants and, well, it used to be mutations, and why is it different? And, what's the difference between a pathogenic and, what's a variant of uncertain significance? I mean, some of these are concepts that, they have no foundation in. And many of genomic applications, if you did them right, are not observable. So for example, in pharmacogenomics, if you ordered the right test and then ordered the right medication at the right dose for that particular indication, based on the genomics, you'd see the expected outcome. And so what's important here is this concept of observability, right? If a patient has pain and then they get better, that's observable. But, depending on what you're doing, you may not see observability. And that lack of observability means they have to have a foundational underpinning sufficient enough to understand why they don't see something. And what's important is that you don't always have to do a genetic test. There's some vision that nursing in particular, and I can speak for the US, think that you have to be able to see something. And you don't, but you do have to be able to recognize a phenotype. You don't always have to do a genetic test. So if you had a patient who had pain and you gave them a medication and it didn't work, absolutely nothing happened, you have to think about, well, what's the biologic underpinning for why they had no response? And in many cases, that can be pharmacogenomic in its underpinning. And the language of genomics is complicated. So it's not like they can, pick up the literature and understand it, or, as I mentioned before, talk with their colleagues, because they may not have someone to go to, and it's a difficult language to understand. And I've already mentioned the issue of, thinking about the benefit of infrastructure. So, in general, most leaders think that they don't need to know these things because that's for their clinical experts and their clinical practitioners that work for them, and not for them. But they have to understand this enough to be able to understand the value of supporting these kinds of infrastructures that enable effective use of genomics in clinical practice. Next slide, please. We know that waiting for the future workforce to solve this problem is worrisome. We have a lot of people who think that that's the way to do it. We'll just wait. But what we know is that faculty from our studies, faculty's genomic knowledge is equivalent to the students that they're teaching. So you have to think about this in the broadest way possible. And that our licensure exams currently have no genomic content at all. Some certifications have introduced a little bit, but not sufficient. And so I've been working with my colleagues at the American Nurses Association to integrate genomics into the scope and standards of general nursing practice, because that drives education, it drives licensure, it drives certification. And so it's a way to try to ameliorate some of this. But we'll see, there's a lot of resistance, I can tell you, in that committee to thinking about this. And the existing training model that includes clinical experiences in genomics, you may not have it, right? So we have a lot of that here at NIH. But if you go out to Joe Blow Community Hospital, in whatever region of the US, you can't be assured that you're going to be able to have clinical experiences that are sufficient enough to teach people about genomics. And so we've advocated for novel strategies, from, case studies to the use of standardized patients for training, but they need to think out of the box as a way to do this. And we need to work interprofessionally. That's the way we practice. And that is a way that we need to think about this education. And it's important to get a handle on this, because we're sort of past genomics. Now we're into precision health and precision medicine, which builds on genomics. And so there's a huge hurdle to rise to be able to achieve, competency for nursing, which is what I'm interested in, being a nurse. So next slide, I think it's my last slide. Okay, so despite what's happening here, Washington actually is very nice. So I hope that you'll come and visit sometime and look me up. And you're certainly always welcome to get in touch with me. Next slide. I put my contact information if you have questions or anything that I can provide.
Thank you so much. That was really, really interesting. From my perspective, I am definitely seeing so much that basically is a reflection of what's happening for us within England at the moment. We have the issue, I suppose, in England that we're one of several nations within the UK, and we have different although we're all under NHS, we all have different views, policies and funding, etc. So I can see a lot that crosses over, and certainly the work around the competencies is something that we're looking at in a lot more detail now. So there's a lot of specific competencies which have all been updated now, and which I'm happy to share with you as well, which are, some of those are cancer specific. So it'd be quite interesting just to share some of those with you as well. I don't know, does anyone have any questions at all? Or have we all stunned everyone into silence at the moment? Phil, I knew you'd have a question.
Thank you very much, Kathy. That's really interesting. And it's quite similar, I think, to what we see here. But I think my basic question, apart from thinking about the higher institutes, the educational institutes, and thinking about who's educating, like who's educated the educators, I think is the biggest issue. But also it's about how do we, as nurse leads, how do we help nurses make the connection between genomics and the care they provide, especially with current pressures and limited time?
Yeah, so, I rely a lot on being able to link genomics to the kinds of patients that they're taking care of and to give them tangible clinical examples, and speak to, the kind of patients that they're seeing and what they're doing, to make it relatable to them. And where does genomics fit in this trajectory? I use a lot of family examples, and how things relate to family. So for example, my father is the classic example of the person who clearly had a pharmacogenomic underpinning that impacted the use of pain control. And I could figure it out when he had his first surgery, because they continued to give him morphine until he developed respiratory depression. And after the fact, when I talked to him, he said there was no pain control at all. And then he had the respiratory depression. And that is an indication of the phenotype associated with that pharmacogenomic underpinning. And, he was in a community hospital because short Italian man, right? You only get your care from the hospital that you were born at. I don't know where that came from, but that was a family thing. And I use that example because I talked to the providers there and they didn't understand me and they refused to hear me, which was especially disturbing. And so I'm an academic by nature. I've always been in some kind of a research and academic environment. And so off we went to get the remainder of his healthcare at, the large academic university hospital in his community. And the same thing happened. And then many years passed and my brother had an episode because he's clumsy and he had a significant injury. And my brother had the same thing. And the thing that's so fascinating is that, my father, I couldn't convince a single healthcare provider, even at the university hospital, to understand this underpinning, even with evidence and papers and so forth, that nobody would listen to me. And my brother, who's a lawyer, has nothing to do with this, could understand it. And he said, do you think I have the same thing that Dad has? Yeah. And so these clinical examples and making it real for people help them to understand, and that there's barriers, because healthcare providers, even though they're evidence-based, it's like, this was what I was taught to do and this is what I do. And getting them out of that box requires clinical examples that they can understand, that are customized to them. We do a ton of genomics here, and we do a lot of that because we've spent a lot of time helping them understand how important it is. And now we can't have clinical case conferences without one of my genetic counselors participating. And that's critical, right? Because it's also a learning opportunity for them. And so being able to embed experts in these environments where people both take care of patients but learn is really, really important. Or I
Thank you.
think.
Yeah, I agree. Thank you.
Before I butt in with yet more questions, has anyone else got any questions for anybody else at all? Doesn't have to just be Kathleen, but if anyone has any other questions. Okay, right, I'm going to butt in then. So what I'm interested in is you've managed to get information from across the US about the nursing capacity. How have you actually managed to do that? Because we have found that so difficult to do within England, and we have these specific genomic medicine service alliances. We did attempt to use the Assign E toolkit, but it really just did not work in the way that we needed it to. I think it would have been brilliant. When I was speaking to Emma about it, I suggested we could use it in departmental bits and then start to expand out for doing that. But to try and do it on such a large scale was really difficult to get that information from clinical staff about their knowledge. And also, as you said, they don't know what they don't know. So, you know, we'd have our FH teams, so our familial hypercholesterolemia teams, quite happy to say exactly what they did because we have nurse-led service in both the West Midlands and our Wessex areas. We have those, so we could easily say what the skills were, what was needed, who needed to know what. But everywhere else where that wasn't the case, had no idea. They didn't know what levels. So I'm just intrigued that you've managed to gain information from other places within the US.
Yeah, so I think the key thing to me, and I don't think we're as successful as it may appear, right? And US is quite large and very different depending on where you are. There's the North and the South and the East and the West, and then there's the middle, and they're all quite different. But the key thing is, to me, where we've been successful is when we've identified champions that are either local, regional, or even embedded within an institution. That whole champion concept, similar to our faculty initiative that we did, which is champion-based, that it's a hard thing to do, and it can't be a one and done. You have to nurture these champions, and that's a limitation because, you know, we have, you know, limited infrastructure to sustain those champions. But that's my current advice to the American Nurses Association, that that's what we have to do. You have to not just provide the mechanism where we can train champions that are regional and local, but that we can sustain those champions and not hope that they're going to do it on their own. Because there is this thing, well, we've done that, so we don't need to do it anymore. But it's a massively changing and evolving knowledge base. So yes, we do have to keep doing it.
Yeah.
And there's the influx of new nurses that are not getting that training in their academic program. The current plan is to pull together all of the large organizations associated with nursing, that, you know, the education groups, the large nursing groups, and that is the strategy, is to come up with a feasible champion initiative. That's the only initiative that we have been successful in achieving sustained outcomes.
That's interesting.
And you have to champions that train other champions, right, within their environment, because they're not going to work forever. So they may change posts and then that person is gone. So you need to build an infrastructure that sustains that, because this is a moving target and the evidence base continues to build and evolve. And until we fix the education foundation, we still need to provide that support.
So thinking about education, Phil, who is alongside Karen incredibly enthusiastic about education and making sure we sustain education, how we actually get that running through not just those post-registration nurses, but those who are teachers, those who are the students. How do we keep that going? So Phil, I believe you have some slides you wanted to share, or are you not doing that, or do you just want to talk about the bits you've done around the... You're on mute. On mute.
I was just going to share some general education slides about some educational updates coming on. But just, I mean, I can just talk about it. Karen's mentions the genomics learning passport for midwives. I basically copied Karen and did exactly the same for nurses, because and it's really important. You know, we are under time pressures. You know, we don't have protected time. Many of us don't have protected time for studying, especially for genomics. Our mandatory is very clinical based mandatory training. So it's just about thinking like, how do we support those nurses a bit more? And so these passports have been developed thinking about that time element. So there's so much genomics education around if you go online. And so having developed these guides essentially, where we've listed the genomic education, it's put in a really strategic way, starting from basics, going up to the more complex thing. And for the nurses passport, it is really just like, you know, it's just thinking about the basics. If we can understand the basics, then dependent on our role and our level, you will get a better idea about what genomics means for your patients and the impacts of genomics for your patients as well. So we've done that, but really, you know, and I think that they can be used thinking about the student nurses as well, because again, you know, the genomics education we get in our training is it doesn't match the speed of where genomics is at the moment. So these are guides that can help nurses just gain some knowledge. And then obviously we do a lot of sessions, we do webinars, we go out and talk to nurses as well, and it's quite interesting. I do a number of sessions where you still come to the point where you ask, do you know the difference between genetics and genomics? And many nurses haven't heard of the word genomics. So again, I think those guides will kind of support some of our education sessions we have going on, but the webinars are really important as well, as in just spreading that word about genomics and slowly helping nurses see why genomics is important. And I think that's the key word, is it's about slowly making nurses aware. So that's for me, I think that's the important thing. And I'm not a genetics expert, I'm not a genomics expert. My background is in infectious diseases. So it's just thinking about what experience did I have coming into this role and coming into this field and trying to help nurses kind of get to the same level, essentially.
Thank you. I think one of the other things that I would say to everybody who's on here is what we are about to run a pilot for nurses for access to genomics, and it's taking it at a really basic level. We've decided to go back to face-to-face because we really believe that's important, that people can talk to one another, but also there will be the chance to actually talk to the tutors who are there. And it's being run over 3 weeks, 3 days, over 3 weeks. And it's really is just that demystifying genomics a little bit and making it apply to your practice. And we're going to see how that goes, and hopefully we're looking to the potential for being able to open that up and start to run it nationally, and put it into other GMSAs that they'll start to look at running these as well. But what we also have thought about is the idea of running these for practice educators and for those people at the higher education institutes, so that what they start to see is that you don't necessarily have to teach genomics as a pure science subject. You can teach it as part of all of your practice, because genomics will come into your practice. So we want people to start thinking about case studies and how they can bring that in. So that's one of the things as well that we're hoping to be able to do, that hopefully people on this call will start to be able to sign up for as well. Kathy, I don't know if you know, but within the NMC, our regulations, we have to, as Karen said, for midwifery, we actually have to state that we understand about genomics, and we have a little bit of proficiency within that. And I think it was introduced without any kind of discussion with nursing, in actual fact, or with midwifery. It just suddenly appeared that we would have that. And so it's I'm not going to say it's scary. It's a little bit, for me, it's a little bit contrary, because I'm there thinking, if you don't tell the people who need to teach people about it, and you don't tell people it's in there, how can we use that to recommend it? So to everyone on here as well, I'd recommend that you certainly look at the Genomics Education website. Phil has some slides that she will also put up, and you can also go on the Genomics Education site and download those passports. And the passports are for the individual. They are not for your employer. They are for you, so that you can direct yourself to go through these different elements. What I'm hoping as well is that we'll be able to look at the work from Finland and see if we can actually also put some links in, as well as to Andrea Gretchev, her work. I was speaking to her last week. So she's in Canada and she has an open access toolkit as well. So I think all of these, as well as looking at competencies and seeing how, as an international community of nurses and midwives, we can actually start to celebrate the fact that we have a massive role to play in all elements of healthcare, and genomics is coming to the fore. So we need to grab the opportunity to start to find our places within that and not be taken by surprise at things. And often it just starts with a family history and having that little spark in your head of, oh, I wonder if. We're not asking you all to become genetic counselors or geneticists, but to always have in the back of your mind, could it be? Could there be? It doesn't matter if you feel you're going overboard on it. I think everyone does that at a point, but you start to hold on to things. But please do make use of the resources that we will be sending out to everybody. But thank you all very much for your time. Phil, are you going to put up the links?
Yeah, so I'll just reshare my screen. If it works. So yeah, so as we've been saying, and as we can see on this webinar, genomics is really important, and it is transforming the way we understand health, diagnose conditions and plan treatment. But for genomics to really make a difference, we need to ensure that all nurses and midwives feel confident and supported in this space. And so education is really important, and it's not just for specialists, it's for all of us in every area of practice. But genomics education also plays that key role in supporting equity. So by making sure that everyone has access to the same knowledge and tools, regardless of the role, background or setting, we can help ensure that the benefits of genomics are shared fairly and that no one is left behind. So you've had that information about the genomics learning passport. We've got the one for nursing and one for midwifery, and they are available to download from the Genomics Education Program website. And as I said, and as Karen said, they're really excellent starting points. They're user-friendly guides, and they direct you to those essential education resources that start with the basics and progress to the more specialist learning. And they are designed to fit around our really busy schedules and can also support our validation for NMC as well. And you're going to find all of that and many more on the Genomics Education website, as well as the information about GE Notes that Karen has also mentioned, as well as e-learning for health platform too. We also have some upcoming webinars, and this is with collaboration with the other 6 GMSAs as well. So we've got a webinar on the 20th of May, and that is just giving us some an introduction to genomics and why it's relevant to you. And then on the 17th of June, we've got genomic testing, consent, ethics, and research essentials to be aware of. So I'll be going through, I see there's a question in the chat about insurance, so I'll be giving some information there, but also thinking about those ethical issues when we are consenting patients, and thinking about results and thinking about those family implications. And then on the 23rd of July, there is another webinar thinking about those family history skills and how it helps. Taking a family history will help us identify those genetic risks. So those are upcoming webinars for you. But if you wanted to know more about genomics from Central and South and applying it in your role, you can sign up to our newsletter and you can receive updates on the events, projects, and any resources and research and much more. And finally, we do have a post-webinar feedback form that we would be really pleased if you could complete. We really value any feedback that we receive. And also, it's also a chance to let us know what topics you would like to see in the future. Now, this webinar has been recorded, but we will be also sending out the information, so you'll get those links as well. But if you sign up to our webinar, our newsletter, you'll get all that information there as well. So I think that is where we are.
Yes, so thank you very much to all of our speakers. We're very grateful you're all coming to talk. And thank you very much to everyone who's attended. And I hope that it has sparked some interest in you about your role with genomics. One of the things I like to say to people at the end of anything like this is, I do have some asks from you. One, do fill in a survey for us. We need that information from you about what else you would like to know. But also, I'd like you to go away and think about, how does genomics fit into my practice? Is there something that I might not have thought about in the past? Secondly, I would say, please go and talk to your friends, talk to the people that you work with about genomics and how it can make a difference, because it isn't a scary thing. It is actually really exciting. It isn't just for researchers. It isn't just for genetic nurses. My background, I was a theatre manager for years. It was so relevant to what would happen in a theatre. So please think about this a little bit laterally as well, because it really involves all practice. And you guys, you're the lifeblood for us of healthcare. And I think that you taking this on that little bit further as well is just going to continue to show how much we need to be valuing our professions. So thank you all very much. And I look forward to seeing you again on another talk.